A very warm good evening, everyone. Very happy to welcome you all to the MedTalk series organized by MMC Pharma along with IGCP. Myself, Dr. Madhuben, the Medical Director of MMC Pharmaceuticals. I'm basically a gynecologist and an IVF specialist practicing in Chennai. This evening is really special to all of us because we have a pioneer in the field of reproductive medicine, Dr. Kamini Rao ma'am, with us. It's indeed a privilege for me to introduce Dr. Kamini Rao ma'am. Of course, ma'am is very well known to all of us and she doesn't need any introduction. But still, ma'am, with your permission, I would like to share a few words about you. So, ma'am is a Padma Shri. She got her Padma Shri award in the year 2014 as a recognition for her distinguished service in the field of reproductive medicine. And ma'am is the co-founder and chairperson of Medline Academics, and she is also the co-founder and the medical director of Dr. Kamini Rao Hospitals, a unit of Medline Academics. Ma'am has been awarded with so many honorable awards, few of which are the Karnataka Vaidya Ratna Award in the year 2021, the Kempagowda Award for Achievements in the Field of Medicine in 2018, the Rajyo Sattva Award for her invaluable service in the year 1997, and the BC Roy Award by the Indian Medical Association, and the Honorary Fellowship of the International Academy of Human Reproduction in May 2021. She has got the Lifetime Achievement Award from ESAR, from Lifetime Achievement Award from Foxy, and the list goes on. And ma'am is the author of the Infertility Manual, which I would say would be the Bible of all the reproductive medicine specialists in India. We Next to Gardner, the book all the reproductive medicine specialists in India follow is, I would say, ma'am's book only. Almost all of us are a student of Kamini Rao ma'am, and also I was also a student of yours, ma'am. I had my embryology training from your center, and today we have ma'am to talk about a very important topic, recurrent implantation failure. As we all know, implantation is very important in a success rate of our uh, IVF treatment. There has to be a synchrony that has to happen between the endometrium and the embryo, and for us to have a successful pregnancy. Even in implantation, there are so many problems that happens that leads to implantation failure. So today we have the experienced specialist who is here to enlighten us with the problems that we could face in recurrent implantation failure. Thanks for the time, ma'am. Over to you. We are very eager to hear from you.
Thank you. Um, Thank you very much for giving me this opportunity. And it is my pleasure to speak to you on a subject which is both of nutritional value, which is an everyday thing that we think, oh my God, it's only nutrition. But how important it is to go back to basics and to understand that the very essence of life and to understand that this essence of life is back to nutrition. It's not about drugs, it's not about high funda, but it's about the basic molecules of essential amino acids. Okay, so if we look at this, let us now go across and have a look at what are we going to be looking at in terms of role of amino acids in recurrent implantation failure. Now, we have to understand what is the scope of my talk. And the scope of my talk is to define recurrent implantation failure and the pathophysiology of a repeated implantation failure, and how do amino acids play out in reproduction, and the practical insights for fertility specialists, and finally, what messages do you take home? Now, implantation is basically a crosstalk between the embryo and the endometrium. And the key for a successful pregnancy includes the apposition and adhesion, invasion, and decidualization. So, RIF, failure, lack of implantation after the transfer of several embryo transfers. So, we don't say that one embryo transfer failure could be called recurrent implantation failure. At least three transfers failed could be classified as recurrent implantation failure. Now, what do we see here? We see a cascade, okay? And what you're seeing here as a tunnel, you're seeing the tunnel here. And look at this tunnel here. What do we see? What happens on day one? This is the fimbria here and the ovary. And here, what we see is the progesterone and the estrogen that is helping. And once the follicle, the embryo goes in here, this is the oocyte, and the fertilization takes place here. So, in the ampulla, okay? And once from the ampulla, it then goes through to becoming a zygote. And once this is the day one, then it goes to the ampulla, and in the ampulla, it becomes a two-cell stage embryo, and then, of course, a four-cell, and then it moves beyond that over here, and then you will see that this embryo keeps actively dividing, and this is day 3, which is an 8-cell embryo and a 16-cell, and then becomes a morula, which is at the isthmus. Mind you, this is at the isthmus of the fallopian tube. Then on day 5, you will see the trophoblast, and of course, you will also see the inner cell mass, which is here. Then this is, of course, the blastocyst, which is hatching, and then you will see once it is hatching, it will then implant into the endometrium. See here, this is implantation. So, when you look at the hatching part, you'll see that on the hatching part, okay, so you will see here, okay, what are the things that are important here? The activins, the inhibins, the DNRH, and then you will see the sex steroids and the HCG. So, what do you see here? Now, you will see here the oocytes and the embryonic expressions. What do you see here? Activins and the GnRH. Okay. So, then what will you see here is that in this particular thing, there is the pre-implantation embryo development. Okay. And now, what happens is, let's go to the next slide. Now, is it simple? No. By no chance it's simple. The human implantation and decidualization is the part of the development here, window of implantation. Now look at all the models that you have here. What are these? These are the pinopods, which are structures that will suck in water. And this one is an L, which is the selectin ligands. And this is L-selectin. This is the MUC1, the endometrial stroma cells. These are decidualized endometrial stroma cells. These colored large structures are the macrophages, and these are the uterine natural killer cells, and these are leukocyte inhibiting factor 1. Now, when this blastocyst arrives as a visitor into the endometrium, the inner cell mass here with the trophoblast there, it comes here and then looks for some space to implant. What happens here is that these are all glands here, and these are the blood vessels. So, In the luminal epithelial cells, you will find that this blastocyst starts rolling over and the apposition occurs. Once the apposition occurs here, these glands are all here. And these endometrial stromal cells all come closer here near the pinopods. These are all pinopods here. And it gets stuck here. These are the L-selectin ligands. So they get selected onto this, the inner cell mass being here. And then slowly what happens is that this entirely gets embedded into the endometrium. So when it gets embedded into the endometrium, you have a cytotrophoblast and then you have a syncytiotrophoblastic. The cytotrophoblast becomes the embryo and the syncytiotrophoblastic becomes the placenta. And here is the adhesion and attachment, and then you will see the invasion and penetration. Then finally what happens is the entire things amalgamate and it becomes a decidalized embryo. Now, in recurrent implantation failure, no pregnancy after 3 or more embryo transfers with good quality embryos. More specifically, it's a failure to achieve clinical pregnancy after transfer of more than 4 good quality embryos or in more than 3 fresh or frozen cycles and in women less than 40 years. And even with good quality embryos, implantation may still fail, can occur in both natural conception and ART. Recurrent implantation failure is a complex and a multifactorial condition. So, what would be affecting the implantation failure? One, it could be the maternal age, it could be sperm quality, it could be the BMI of the woman, it could be microbial metabolites, antimicrobial substances, antibiotics, it could be endometrium, endometriosis, hormonal factors, and of course, immunological factors. And very important is the stress factors. So, who's at risk and what causes it? Who is affected? Who's affected? Any couple undergoing infertility treatment can encounter recurrent implantation failure. Next is immunological factors, endometrial receptivity, thrombophilias, microbiomes, anatomical factors, and these are, of course, fibroids, adhesions, anomalies of the Mullerian kind, endometriosis, and hydrosalpinges. And male factors are embryo aneuploidies, that is, chromosomal abnormalities. So, we have to consider all this in this case. But in the diagnosis, the challenges would be the initial evaluation should be structured but individualized approach. Investigate factors affecting oocyte and sperm quality to improve embryo potential. Next is to ensure optimal embryo assessment in well-controlled lab conditions and thoroughly assess the uterine environment for receptivity. Time the embryo transfer to match the window of implantation. Very important. Now, What would be the new considerations that we see today is chronic endometritis, vaginal microbiota, immune profiles, empirical immune modulatory treatments, and guidance follows evidence based information. So, where do we see amino acids in the development? So, biosynthetic energy substrates, regulators of energy metabolism, pH buffers, osmolytes, antioxidants, and chelators. Now, amino acids minimize the stress within the embryo by facilitating cell function and maintaining homeostasis. If you look at the abnormal amino acid metabolism and poor pregnancy outcomes, let's look at the abnormal amino acid metabolism. Now we have the transfer RNA increase. Then you'll see all these kind of names coming here, the GCN, then the IF2 alpha and the ATF4 increase, and that has a lot of phagic kind of a function called autophagy, and that will be A in the endometrium. What about SGC707? Again, you will see apoptosis occurring in this kind of group, which is PRM3 and ADMA increased, NOS decreased, and nitric oxide decreased, and that releases in the trophoblast called apoptosis, and that becomes B. Now let's look at inflammatory response, which is the cysteine. That is vitamin B6, the CBS decreased, and that also decreases the vitamin D levels. The homocysteine is increased, NK cell cytotoxicity increased, and it leads to inflammatory immune responses, and that is category C. So you have in endometrium, which is autophagy, so that it can actually kill the embryo and just gobble it up. In the trophoblast, they have a sense of apoptosis. And in the maternal fetal interface, which is category C, you have the inflammatory immune process. So these are all regulatory mechanism with abnormal amino acid metabolism. So we have to be very careful in looking at this. So if you look at the summary of personalized medicine, summary of etiology would be and treatment options for the RIF are maternal and intervention. So if it is anatomical, then salpingectomy, fibroid removal, polypectomy, endometrial growth. Then what about thrombophilia? Low molecular weight heparin. And in genetics, you'll be looking at ERA, PGS, and karyotyping. If you look at immunological, then we're looking at tacrolimus, IVIG, and PPMBC, GCS. And if you look at infection, antibiotics, altered molecules, and endometrial receptivity, we look at endometrial injury, like either coring or scratching, and then we look at GCSF, granulocyte colony stimulating factor. What about others? Embryo, look at in the intervention PGS, okay, and PGD. Male factor, stop smoking, and IMSI. IVF protocol, optimize the protocol. So this is what we will call as personalized medicine. Next, what is the amino acids in reproduction, which will be the 9 essential amino acids. They are phenylalanine, valine, threonine, tryptophan, methionine, leucine, isoleucine, lysine, and histidine. Now, they're all required in reproduction. In oogenesis, oocyte development and maturation, protein restricted diet impairs amino acid kinetics and oocyte mitochondrial function. Deficiency of essential amino acid disrupts estrous cycle and equality. And in spermatogenesis, the Sertoli cells rely on glycolysis. Glucose is the main ATP source. Alanine serves as the key glucogenic amino acid. So here we find that in all these kind of situations, you have one, the Sertoli cells depending upon the glucogenic amino acid. So let's look at this. Arginine, leucine, and glutamine support is required for conceptus growth. Leucine and arginine have been shown to stimulate implantation. Glycine, leucine, and taurine supplementation during pregnancy helps to overcome fetal growth restriction and supports healthy fetal development and long term outcomes. Very important. So let's look at the three interfaces here. You have the mother, you have the placenta, and the fetus. So if you put all the three together, then you would see in the mother you have, okay, the maternal amino acid pool, and then maternal, you will find that in the maternal side, the maternal part metabolism, and of course you'll have the gut microbiota. There is exchange transporter systems to and fro from the placenta and the maternal side, and accumulative transporters. Here in the placenta amino acid pool, you have a lot here, and again you have a facilitated transporter to the fetus and an exchange transporter in and out. So fetal amino acids here and protein synthesis for the fetal pool. Okay, so once you have a fetal pool here, you will see that for fetal development, that is what is required. So you have three parts here, and the placenta acts as an in between. So we need to be careful that the allograft, which is the fetus, has one layer between the mother and the baby. So the placental villi bathe in the maternal blood. So there is no direct contact of fetal blood with the maternal circulation. Okay. So next we look at amino acids in the cellular metabolism and embryo development. Favorable for implantation is the cleavage stage support, that is proline, glutamine, glycine, and methionine. Leucine uptake, heterochrony, hmm, hmm, okay, glutamine, glycine, and methionine, leucine uptake, heterochrony, and the variation in timing of the BO and expression, that is an evolutionary mechanism that optimizes implantation across the species. Now here, not favorable for implantation is a disrupted leucine uptake, impairs embryo, fetal, and placental development when system BO fails and the function is altered. Long-term health consequences, adiposity, CV dysfunction, cardiovascular dysfunction, neural abnormalities, altered bone growth, epigenetic modifications, transgenerational impact, and heritable health problems. Look at the gene protein differences here. The Endometrium shows different gene activity and protein levels between the pre-receptive and the receptive stages. The role of amino acids and carnitine, that is alanine, valine, and carnitine, help at different levels during these stages. Potential as biomarkers and molecular changes may help identify when the endometrium is ready for implantation. Need more research on these things. So, what is crucial for uterine environment? Amino acid regulate endometrial receptivity, angiogenesis, and immune modulation. Maternal diet affects amino acid composition of human uterine fluid, which may impact pre-implantation embryo development and maintain vascular homeostasis by influencing endothelial cell function. It also maintains vascular homeostasis by influencing endothelial cell function. What about the implantation window and angiogenesis? Now, angiogenesis is hormone driven, and the estrogen and progesterone regulate angiogenesis during the implantation window, and it is critical for embryo and implantation nutrient delivery. So, essential roles in reproduction: support implantation and early embryonic development, influence maternal fetal communication and placental function, arginine, glutamine, leucine, and carnitine stimulate conceptus growth, promote pregnancy maintenance, and improve overall pregnancy outcomes. L-carnitine improved the development competence of their oocytes after insemination. So, it's important to understand that amino acids play a very vital role in all these situations. Okay, so given that it improves all these things, it is important to understand they become very essential. Then what about glycine, serine? Hmm? Glycine, serine, and taurine, they aid in fetal development, help mitigate fetal growth restriction, and when supplemented, taurine, osmolalite, and antioxidant improves embryo endometrium dialogue. Okay, important for the regulation of gene expression, protein synthesis, and angiogenesis. Proline modulates signaling pathways which influence trophoblast invasion and decidualization. But looking at the implantation biology, the role of amino acids will be, of course, it will be um, the amino acids that we have here will be dietary amino acids, that is L glutamine and L alanine. What do? They increase fetal growth and viability. Methionine enhances the embryo survival and exerts an antioxidant active function. L-arginine increases embryo survival and inhibits embryo survival. N-carbamyl glutamate increases embryo survival and suppresses embryo losses. Taurine possesses antioxidant and anti-inflammatory properties. Leucine, positive impact on embryo implantation and embryo survival. And proline improves reproductive performance. The benefits of amino acid targeted therapy in pregnancy. We look at the dietary amino acids that comes into the amino acid pool, the amino acid synthesis, and the tissue protein degradation. If you look at the imbalances in maternal amino acid metabolism and fetal programming, we will look at reprogramming, and from amino acid targeted therapies, you will see how it programs the pregnancies and goes back over here. Whereas it targets one liver, ovary, kidney, heart. So all of them are sort of influence, and this is where the fetal programming occurs. Cardiovascular, kidney, and metabolic syndrome in later life. Now, in insight, practical insight for fertility specialists when to consider amino acid support in clinical practice. Nutritional and supplemental approaches to correct amino acid imbalances and aligning amino acid support with fertility treatment. So, one, consider amino acids when there is a poor ovarian response, embryo development, support IVF and advanced maternal age, endometrial receptivity issues, in recurrent implantation failures, male factor infertility, nutritional deficiencies in couples trying to conceive, and to support gametogenesis and early embryo development. Now, when you say targeted, nutritional and supplemental approaches to correct amino acid imbalances, targeted supplementation, use specific amino acids like L-arginine to enhance blood flow and endometrial receptivity. L-carnitine for improving sperm motility. N-acetylcysteine to reduce oxidative stress. Glycine and serine for cellular repair and embryo development. Dietary optimization encourage protein-rich, balanced diets to maintain amino acid homeostasis. So, if we are to look at the amino acids in reproductive health, we come across a lot of these things which have been mentioned in the reports of amino acids in reproductive health, and that actually covers up a lot of deficiencies here. So, keeping in mind that these low egg qualities and egg reserves also can be brought up by amino acids and nutritional supplements approaches to correct amino acid imbalances, the antioxidant properties of amino acids are all being used for bringing in the healthy reproductive system. How do you align amino acid support with fertility treatment? The pre-treatment optimization will be at least 1 to 3 months before the start of fertility treatment, that is, amino acid correction before the ART. Supplements regulate mitochondrial health and promote energy supply, one carbon metabolism, biosynthetic pathways, and infant health. Second, during stimulation phase, continue the selected amino acids to support follicular growth and endometrial development. The third thing is post-embryo transfer, support embryo development and amino acid transport and metabolism. Okay, cold water, cold water,
Cool water.
cold water.
Yeah.
And post-embryo transfer, support embryo development, and amino acid transport and metabolism are essential during pre and peri implantation stages. Collaborative care model, coordinate with nutritionists for comprehensive care plans. So, whereas the various clinical evidences in clinical trials, insights from animal and human studies shows L-glutamine supplementation, L-arginine in heart, L-carnitine in endometrial support, amino acids in IVF IUI success rates, L-carnitine in improving embryo quality in vitro fertilization, embryo transfer, impact of vitamin E, impact of zinc and selenium. What would our takeaway messages be? That RIF is the failure of implantation after multiple high quality embryo transfers, still a major IVF challenge is there. Amino acids like arginine, leucine, glutamine are essential for embryo development and maternal embryo communication. Leucine and arginine stimulate the implantation. Their absence can induce embryo dormancy and in culture. Supplementation with glycine, leucine, and taurine helps overcome fetal growth restriction and supports healthy development. L-carnitine enhances oocyte development, competence, and embryo quality even without changing the initial oocyte parameters. Amino acid based nutritional support is a promising, safe adjunct to conventional fertility treatments and culture media optimization. And with these few words on amino acids, I think we are now getting back to basics and back to nature. In rather than being treated with drugs and treated with so many other medicines, we are now getting back to nature and trying to use supplemental nutraceuticals to be able to help our body to supplement more and more natural products for us to be able to help nature to help the oocytes to get better and the endometrium to implant much better. Thank you all very much for a patient hearing.
Thank you so much, ma'am. Thank you so much for such an elaborate discussion about the each and every amino acids that is very important for the fertility life in the reproductive age group. Um, as you were rightly saying, as gynecologist or an IVF specialist, we are more focused on finding out the various etiologies or the pathologies that is causing the recurrent implantation failure. And I think now it's the time we have to go think about the nutritional problem as well, uh, as because of all the junk food and all the lifestyle changes that is happening in our country. We should start focusing on the nutritional aspect as well. And as you were telling, every amino acid has its important role in the reproductive system. Thank you so much, ma'am. There are a few questions put up. Can I
Thank
just start with the questions, ma'am?
Yeah,
One
yeah,
from Dr. B. Amarnath. He has asked, what are all the amino acids? I think it's already been answered from the take home message slide itself. Ma'am has given everything in precise. What are
yeah.
all the amino acids and what are all its uses? So, next, I have few questions, ma'am. Which amino acids you think are important for endometrium, especially, ma'am?
I think if you look at what my slides tell you,
Yeah,
that we
it's all.
have carnitine, which is good, and we also have methionine, which is good. What is important is that very specifically we have to individualize it. One, if you look at the microbiome and we look at also those that are helping the endometrium, and the idea of using these these uh,
Supplements.
nutraceuticals into the endometrium is it that they act like phages and remove or take out the bacteria from the endometrium, and the very low grade endometritis that you see and which prevents that recurrent implantation failure, but it is to be given before, at least 3 months before, and that is the thing that we actually think will be helpful. Now if we are going to give it inside the uterus, for example, I would expect about 6 days, between say day 9 to 16 is what I would expect if you are going to give it into the uterus. But if you're giving it orally, one would expect that in poor ovarian reserve or where there's a thin endometrium, provided there's no organic cause for these endometrium, I would like that the endometrium be treated for 3 months before you start the treatment. Otherwise,
After
giving it
one
for
implantation failure, we can go for 3 months. So that's what you
yes.
told. Yes. Thank you, ma'am. Thank you so much. And can amino acid profiling in culture media can help in implantation, ma'am?
See,
Just
most of these amino acids are not as stable as you think. The essential amino acids, they're called essential because they are not produced in the body. Okay?
we have to give
So they have to be supplemented. Now, when
supplemented.
you give these amino acids, some of them which are given, the amount, I mean, it may be there in the body, but may not be in sufficient amounts, for example. And some of these deficiency of amino acids also lead to inborn errors of metabolism. So, when you're actually trying to support these amino acids, either we give insufficient or we give too much. So we must know when to start, when to stop. All these amino acids. And when you give these amino acids, like for example, it's not that you have to just go on giving it till the 34th week of pregnancy or something like that. It's not required.
I was about to ask the next question, ma'am. How long? How does long-term amino acid supplementation will affect? Because we are always talking about the goodness, but are there anything that would affect the newborn or the fetus?
In
How
fact,
long we can?
yeah. See, there is no need for us to give see, like for example, if you're already full, your stomach is full, if you go on stuffing food inside, either you will vomit or you'll have diarrhea or a stomach upset. So therefore, there is a limit to which you can take. Too much is bad, too little is bad. So there has to be an optimum value that you can take. So if you ask me, can you go on taking? Now this is not peppermint. You know, you have to have certain norms and ranges, and one, make sure there is a deficiency, then make sure there is a level called sufficiency, then you stop. Why are you going on giving? You're only making the pharma companies rich, that's all. You're not helping the patient.
Just for
And
practical point of view, ma'am, as you already told, one if there is an implantation failure for the first time, and then maybe we go for minimum 3 months of amino acid supplementation, and then go ahead with the next embryo transfer, and then once if she becomes pregnant, that cycle, how long we can continue, ma'am, until like 12 weeks or 8 weeks? What would be your suggestion, ma'am?
in fact, if you're giving it 3 months prior to the pregnancy itself, that itself should support. There's no
Okay.
need for you to continue beyond, because it would have actually given you adequate sufficiency. But if you are going to give it even during the pregnancy, maybe 8, 9 weeks perhaps would be the best time to take it off. It's not required. Like for example, when you're giving iron supplements or calcium supplements as well, it's the same. I mean, nobody expects you to start it within the first 3 months, because as it is, if she has some nausea and vomiting and you're still giving iron at that time, it can cause problems. So it's better to start iron in the end of first trimester of pregnancy, when all the organogenesis is over, and then you give them. And if you're giving calcium also, it is well known that if you're giving calcium, too much of calcium, it can also cause kidney stones. So
Yeah.
we must be careful. And if you're talking about vitamin D, it's the same story. Don't give two, because we've
Or
seen
with
toxicity with
doses.
vitamin D also.
Yes.
So everything should be in right measure. That's what I would say.
Until organogenesis, approximately 8 weeks should be sufficient, right, ma'am?
Yes. Yeah.
Okay. And ma'am, like, is there any correlation between measuring the plasma amino acid level and then trying to find out the implantation outcome? Is there any test that we can do to measure the plasma amino acid levels that you would suggest
I think they don't actually, sort of
as a routine?
mirror image the tissue amino acids to the plasma. So
Okay.
if you are looking at it, it will not mirror image. Like even
No.
the NK cells, for example, that you see, the uterine NK cells and the
Mm.
blood NK cells don't match.
Mm. Okay.
So what you're looking for amino acids is the tissue amino acids, not the
Okay.
plasma amino acids.
Okay.
So that is the reason why when you're doing this, like you say, like TH1 and TH2 and everything, the
Mm.
TH2 is supporting and the TH1 is not supporting the pregnancy. So
Yes.
the way of measuring them is that although they have made certain capsules which will actually give more of TH2 rather
Mm-hmm.
than TH1, etc., but
Mm.
that is not measured in the plasma.
Okay.
Okay,
Okay, ma'am. Thank you
sure.
so much, ma'am. That was a really brainstorming session. Thank you so much for your giving your time and energy and everything. Even at this age, you are really very active, and then you still look very young, ma'am. So I'm not talking about the age here, but still, you would still look very, very young. And thank you so much for this opportunity for being a part of this program where you are here. It's a honor to
Sure.
me, ma'am. Thank you so much.
Thank you. Thank you. Bye.
Thank you.